Hello, and welcome to HHQI's Underserved Population Network Quarterly Webinar. I'm Shannon Wright, the Director of HHQI. We also have the following HHQI team members on the call today. We have Sharon Miller, an RN Project Coordinator for HHQI, as well as Crystal Welch. Misty Dyke is our Communications Lead producing today's webinar, and Andrea Lefke joins us from Communications as well. We have a few housekeeping measures before we begin today's presentation. The slides are posted on the HHQI website. Misty will post the link in the chat box as well. You may need to click on the chat box on the top right corner of your screen to open it. Note that all participants' phone lines are muted. Please use the chat box or the Q&A box in WebEx to post your questions and comments for the speaker as we go along. We'll entertain as many questions as possible, so please post them early. We are very excited about today's webinar presentation, Engaging Caregivers as Partners. I'll introduce you to our guest expert in just a few minutes. Today's presentation offers 1.25 hours of continuing education credits in HHQI University for nurses. You will need to watch the live or recorded webinar and completed reflective questions and evaluation in HHQI University. We will have detailed information at the end of today's presentation. Nursing CEs are approved by the Alabama State Nurses Association through the American Nurses Credentialing Center's Commission on Accreditation. Any questions related to CEs, please contact our mailbox at hhqi@qualityinsights.org. That email address will be located at the end of the presentation as well. I'd like to introduce you to our guest expert and a partner with HHQI for over 12 years. Dr. Warren Aber is Chief Executive Officer for the Home Care Association of Louisiana, with a demonstrated history of working in the home health and hospice industries. He has a Doctor of Nursing Practice degree focused in executive leadership from Loyola University in New Orleans. Dr. Aber has chaired the National Council of State Home Care Associations, the Forum of State Associations, the Louisiana Rehabilitation Council, and the Louisiana Legislature's Study Group on Chronic Care Management in the Community. He served on the advisory board of the Home Healthcare Nurses Journal and is currently Secretary of the Board of Directors for the Community Health Accreditation Program Incorporated, or CHAP. Aber recently served on the CMS Technical Expert Panel to reduce rehospitalizations from post-acute care. Dr. Aber is a fellow of the American Academy of Nursing and an alumnus of the Robert Wood Johnson Foundation's Executive Nurse Fellows Program. He currently serves as an active HHQI network coordinator and has partnered with us on a variety of projects. Warren's doctoral project was a study of a home health agency nursing staff's understanding and application of family caregiver identification, engagement, and support. Since 2008, Dr. Aber has hosted Family Caregiving on Radio Maria, broadcast on the web, over the airwaves in 9 states. The station estimates 30,000 listeners in a 24-hour period. Warren presents related to transcultural aspects of family caregiving with an article to be published in the Journal of Christian Nursing to be released in coming months. Warren's family provided care over his father's 7-year journey with dementia without one night of institutional stay over that time. Dr. Aber and his wife have a 28-year-old daughter who has Down syndrome and live the potentially joyful family caregiver experience daily. With that, it is my great pleasure to turn over today's presentation to our guest expert, Dr. Warren Aber.
And thanks to thank you, Shannon, and thanks to the QI team, the HHQI team at Quality Insights. I'm very excited to be here with you today, and the good work that the folks on the HHQI team has impacted home health providers across the country. So thanks for your good work and the opportunity to partner with you. We will be hearing a great deal more about family caregivers as a result of congressional legislation that was passed in January of 2018 and signed by the president back then. Health and Human Services is mandated to pull together health policy and strategy across the continuum of care to recognize, assist, include, support, and engage the family caregiver. So we're all going to be hearing a great deal more about that. And in spite of the fact that we as home health providers are in that space on a regular basis, there are a number of things that we can learn about family caregiving, a number of things that we can be more intentional, more tactical, more strategic about with regards to engaging the family caregiver. So we'll talk a bit about that legislation. We'll get into some other specific areas. We'll talk a little bit about the cultural aspects, which are very, very important. Then we'll talk about a number of other things related to aspects of family caregiving. So I'm very excited to have the opportunity to be here with you. I'm speaking to you from Cajun country in South Louisiana, and you're going to have an opportunity during the program here to meet a few of my family members. This is my mom and dad. They were married back in 1956 in June, and a little over 9 months later, I showed up. But as you can see, mom and dad were youthful. There was a lot of vim and vigor. They were hardworking folks, and they really did a pretty extraordinary job. I'll introduce you to the rest of the family in a bit because they're part of the family caregiving story. Here they are a little bit later. Dad dealt with dementia from 1999 through 2006 when he succumbed to some of the complications that folks deal with around dementia. Mom is Dad's primary caregiver, even though she was well into her 60s at the time, and she was fortunate to have a really good group of folks all around her. I'll introduce you to my siblings a little bit later. But certainly the family caregiver there on the right is someone that you need to get to know. And for those of you who are working in home care agencies around the country who are joining Quality Insights gathering here today, you know that oftentimes the family caregiver is someone else who's older. That family caregiver has their own health problems. And so we just need to get to know those folks. We need to recognize that our relationship with them needs to be intentional. And we'll talk a bit about some aspects of that a little bit later in the program. So I want to talk a bit about the Raise Family Caregiver Act. We were very fortunate that the President signed that into law. We're also very fortunate that the folks with AARP have been driving more research, driving the conversation related to family caregivers. Dr. Susan Reinhardt, who was at Rutgers for a while, is now Vice President of AARP's work in the area of health policy and research. And she was the lead author on a number of different studies that we'll talk about in a few minutes. But one of the important aspects of getting the RAISE Act passed was the fact that these co-sponsors were very involved. Congressional recognition of family caregiver value is something that's really critical today, and we're very fortunate that they're finally beginning to identify that. I think that some of their need to recognize that around health policy is the fact that we're moving towards a more value-based payment model, and as a result, the incentives are better aligned than they were with the old volume-driven model. So important for us to be aware of that, and also we're very fortunate that those were folks who were a member of the congressional caucus, and that was called Assist Caregivers Today. I'm going to go back just for a second. It is intriguing to me that 3 of the 4 members of the Assist Caregivers caucus happen to be female. I will not editorialize on that. You can talk about it among yourselves, but it tells you that we're still sort of stereotyping related to caregivers, even though today about 40% of caregivers are men. So let's talk about some of the statistics related to caregivers. This information comes from a number of sources. AARP, again, has just done extraordinary work over the years they identify about 45 million of us that are family caregivers across the country, 7 to 8 million of whom are providing care on a daily basis. Now, there have been a couple of studies to try to address the economics around family caregiving. AARP's work called Valuing the Invaluable pegged that number in the latest update at around $470 billion a year. The RAND Corporation also did some work in this area around 2014, and they estimated the number a bit higher, and the reason is that they used a different formula. They tried to identify the economics related to the family caregivers who were either reducing the number of hours they were working or leaving work completely. And in either of those two situations, the family caregivers also lost benefits. Sometimes their retirement, sometimes their insurance. So the RAND Corporation built that into their formula. And again, the economics are pretty staggering, around $522 billion. In the radio program, I try to put these numbers into context. And around the time the Valuing the Invaluable was done, it was equivalent to the annual revenue of ExxonMobil or Walmart. So it gives you a sense of this pretty significant numbers here. The spectrum of care is much more complex today. Again, the folks at AARP, another study that they did called Home Alone, identified the fact that there are great complexities related to the challenge with medication compliance, the challenges in navigating the system, and also the family member is frequently providing care that would be considered skilled care in our home health settings. We've got an increased number of people who are aging. The statistics that most of you have seen, that I've seen, is that 10,000 of us in the baby boomer generation, I'm 62, I'm part of that generation, 10,000 of us are turning 65 every day, while our families have gotten smaller. And not only has the family unit gotten smaller, but we are certainly living in a much more mobile way than we did back in the 60s and 70s and prior to that. So family members are living across the country or in other parts of the world. That leads me to one of my favorite quotes of the last few months, and that is that Joseph Coughlin, who is the founder and director of MIT's Age Lab, he wrote a book that was published in the last couple of years, The Longevity Economy. It really ought to be mandatory reading for all of us. But Joseph Coughlin tweeted just a couple of months back that independence is overrated. It's interdependence that we need to seek. So anything we can do to put ourselves together with other folks is a good thing. This was the reason that Dad had dementia for 7 years and was not hospitalized or institutionalized for one night. Many of you listening to us today have had experiences within your family, and you had to make the difficult decision around institutional settings for your loved ones. I can't imagine the pain that's involved in that. In our case, Mom had indicated to Dad that she wasn't going to have him institutionalized, and she and Dad had taken some steps to prepare for that. These are me over to the left-hand side and my 9 siblings. Forgive me for the little catch in my throat there. It must be my allergies. Anyway, this is the care team that worked with Mom to help to make sure that Dad was able to get care. Not everybody could stay overnight. Some of us did. We had a couple of sisters-in-law that would come over every day and actually spend the day with Mom helping. We had a couple of, one sibling and her husband worked to the point that they really couldn't help, but they offered to cut Mom and Dad's grass on the weekends. And Dad died back in 2006, and I believe they're still taking care of Mom's grass for her. But it gives you a little idea that, sometimes there's secret sauce involved in this family caregiver experience. So let's go back to the RAISE Family Caregiver Act. To recognize, to assist, to include, support, and engage family caregivers. The law indicates that the secretary is to develop, maintain, and update a strategy to recognize and support family caregivers. This strategy is to be implemented across the entire continuum of care. So the family caregiver who has primarily been ignored over the decades now is going to be very engaged. And I say ignored, there are a couple of exceptions to that. Certainly some of you work in end-of-life care. The family caregiver is very involved there and absolutely involved on the pediatric side. But for the most part, the family caregiver has not only been ignored, but I would go so far as to say that sometimes those of us who are health professionals have a degree of animosity toward family caregivers. You've all heard stories about the family caregiver that walks into the doctor's office with 6 pages from the web and the feedback that person gets. And some of you, like me, have spent time working in a hospital setting. And when it's time for visitors to show up, if they happen to have a family like mine, then you can imagine the crowd that's at the door. So my mom, on the occasion she's been hospitalized, was not lonely, I can assure you. So the advisory council is also part of the HHS Secretary's project, and this is happening through the Administration for Community Living, that part of Health and Human Services. And the advisory council is going to include 15 members, and they're going to be giving recommendations regarding this new strategy. They still haven't announced the advisory council, even though the nominations were due in back on December 3rd. I was told they had over 3,000 nominations. I'm hoping to hear something from those folks any day because I'd love to be part of that. There are going to be representatives from private and public sectors, and you can see the screen. Certainly those of us that are family caregivers. Older adults are going to be included, people with disabilities, veterans, and people who are providers of long-term care and services. This is another part of our caregiving story. This is my wife and I's daughter, Brooke. Brooke is 28. She has Down syndrome. She's very high functioning. And as you can see from that smirk, she is quite a piece of work. Brooke just finished a university program called Life, Learning is for Everyone. And during those 4 years she was on the college campus at the University of Louisiana at Lafayette, she became the first young woman in the history of Phi Mu sorority to have Down syndrome. So it says quite a lot about those young women in that sorority to bring her in. So the family caregiving role is something that can involve lots of different perspectives. I'll add that there are families out there caring for children that are medically fragile, even on ventilators. So the family caregiving spectrum is pretty broad. The ladies down in the bottom right corner are folks that I met on my home health journey. The daughter to the right is taking care of her mom, who's on a ventilator, and mom has been very well cared for. And at the time that we met them, doing some interviews related to family caregiving, her mom had been cared for at home for 2.5 years on a ventilator and had not been hospitalized once. So the family caregiver can develop lots of competencies and skills that are certainly very important when it comes to trying to be sure that we're avoiding readmission to hospitals. The competence piece of it is something that I want to spend just a second with here. Our academic institutions have been educating physicians, nurses, social workers, therapists, and others for decades. And that education has certainly done a great deal for us related to the various aspects of our practice. But the practice setting that they've been training for and educating for is primarily an acute care setting. And there are a few exceptions, some extraordinary institutions, but for the most part, there is not much conversation related to engaging the family caregiver and not near enough robust education going on related to care in the home setting. So that's something that is one of the things that I evangelize about, is trying to get our academic institutions to recognize the need, perhaps even for residencies that happen in a home setting, but certainly for some intentional education related to aspects of the family caregiver's role. We know that poor transitions really make a difference. Many of you are familiar with Dr. Eric Coleman's work, who's a MacArthur Fellow, from his life's work related to aspects of care transitions. So we need to be looking at the research. We need to be driving evidence-based practice in the work that we're doing. The family caregiver often is someone that makes a really big difference, even without being engaged and even with a lot of training. One of the figures that I heard recently is that if someone goes home alone rather than going home to a warm body, doesn't matter whether that person's got any education or training or engagement. If they go home to someone, they are 1/4 as likely to be readmitted to the hospital. So again, let me restate that a little differently. If you're going home alone after a hospitalization, you're 4 times more likely to be readmitted. That number should certainly get our attention, and I think that it means that family caregivers are going to be much more engaged in the process and much more recognized in the future. The outcomes of effective family caregiving. There's engaged, active patients and family out there, and you can see the list there. Certainly the reduction in cost, quality is improved, there's less of a problem with sleep and medication. And what I'd like to point out at the bottom is the fact that we as health professionals, particularly in the home health setting, but I would say this is true for primary care practice folks and in acute care setting as well, we would be doing an extraordinary favor if we did ourselves the practice of treating family and the patient as dyads. This will improve the outcomes for the patient, but also improves the outcome for the family caregiver. You know, I'll add at this particular moment that one of my favorite stories is that of Patch Adams. Many of you remember Patch Adams. Robin Williams played him in a movie quite some time back. And one of the things that Patch Adams said is that his history and physical was not complete until he had dinner in that patient's home with them and their family. Because he said driving into the neighborhood, he had a lot of information related to what's going on from a public health perspective. He also knew about the socioeconomics of the area. When he knocked on the patient's door, he had an idea of that family's financial situation. When he walked in the door, he could learn a lot about their ability to engage and greet people. And looking at the pictures on the wall, he had an opportunity to see what was happening there from a standpoint of the family members that were part of that unit. So, you know, if you haven't seen the movie Patch Adams, I would certainly encourage you to do that. He's definitely a proponent for care and services at home. We'll talk a bit now about a sort of narrow focus related to aspects of family caregiving, but something that I think is very important, and that's the aspect of the ethnic and cultural differences around the people receiving care. Among those 70 and older, whites, Caucasians are the most likely to receive help from their spouses. Hispanics will receive help for the most part from adult children, and African Americans are most likely to receive help from a non-family member. These are just a few of the specifics, and the reason I wanted to focus a little bit on the cultural aspect of this is that it's something that we overlook very often. Some of you may be familiar with the work of Dr. Madeline Leininger related to transcultural nursing. Dr. Leininger recognized that in our efforts at treating people in a holistic manner, that sometimes we overlooked that aspect of ethnicity and culture. And while that's important in acute care settings, it is more critically important when we cross that sacred threshold into someone's home. I happen to live in a neighborhood that's got folks from one gentleman who grew up in China. I've got neighbors across the street and down the street who are from India, people around the corner who are from Thailand, and other folks that are Hispanic and Latino. So in my own neighborhood, I know that when I visit my friends, their house is very different. The food that they cook is very different. So that's something that we know as home health providers, and a lot of our friends in other healthcare settings don't really have that much experience with. So we'll spend a few minutes on this. For those of you who have had the opportunity to dig in a little bit to the literature and some academic work, a meta-analysis is work that someone's done to look at a broad range of different articles, broad range of the literature on a particular subject. So this transcultural meta-analysis, which at the end you'll see that I've included references, and reference number 23 is the transcultural meta-analysis. And this kind of breaks down that Asian caregivers made less use of professional support services than those that are white. Here in the United States, ethnic minority caregivers have a lower socioeconomic status, so they're more likely to receive support from family caregivers. And the filial obligations and beliefs are tighter than that of most of us who are Caucasian, Western European folks. The ethnic minority caregiving groups reported worse physical health. African American caregivers had lower levels of caregiver burden and depression. So again, it's important for us to really understand aspects of the transcultural aspect of care. And I think, again, I'll mention Dr. Madeline Leininger's name. I think it's important for you to be aware of her and her work. And if you happen to live in an area and you've got a broad range of different ethnicities, Dr. Leininger's work certainly would be very helpful to you. This slide speaks to resilience, and resilience is really important for the family caregiver. We all know resilience is important for the healthcare professional as well, but certainly for the family caregivers, knowing that they deal with stress and deal with challenges in a very different way. The rates of caregiving for those 70 and older by ethnicity. 44% of Latinos over 70 were found to be receiving some home-based family caregiving. 34% of over 70 blacks, and 25% of non-Hispanic whites. So again, we see differences between the various ethnic groups. I'd like to talk just a second about aspects of the LGBT community. More and more, our friends in this community, and I think that there are a couple of other letters maybe that have been added to this recently, 1.75 million to 4 million older adults are lesbian, gay, bisexual, or transgender. It's important for us to recognize, again, from a perspective of culture, that there are challenges that the folks in this community encounter that are different from those of others. 1 in 3 LGBT folks lives alone. So we talked a little bit earlier about the fact that if you go home alone, you're 4 times more likely to be readmitted to the hospital. So if you happen to be admitting someone from the LGBT community, just be aware that it makes a difference if they're living alone. And it means that they're going to be at a higher risk for readmission to hospitals. 40% of those who are LGBT who are older say that their support networks are smaller over time. I'll go back to Joseph Coughlin's comment that independence is overrated. It's interdependence we should be seeking. So we should be trying to do everything we can to expand our support network and build relationships. So this is a very important piece of our recognition of the difference in different cultures. Folks that are LGBT also more likely to face poverty or economic difficulty. Despite this, many of the supports in place for aging in America really don't cater to this special group. So it's something for you to be aware of. So this might sound a little self-serving. I introduced you to my daughter a little bit earlier, but I think that those of us who have adult special needs children, and for that matter, younger children as well, are also part of a different culture. We have certain aspects of our family experience that are sort of understood. We try not to be intimidated. While we are like anyone else with regards to not really wanting to engage in confrontation, we're more likely to do that because we've got to be sure we're advocating for our children. So if you have someone that you're engaging in a home setting and you've got family that seems to be perhaps a little stronger of an advocate than the average family member, just know that that's something that we've had to deal with since our children were tiny. And we've been through not only dealing with healthcare providers, but also dealing with the school systems, with education, et cetera. And I'll tell you that for the most part, our experience has been wonderful. There's been a great deal of love over those experiences, but on the occasion that the love is not there and people feel like, our children with special needs are making life difficult for them, we can certainly advocate for ourselves. So expect that from those families and try to understand where they're coming from. We're not afraid to show emotion. You heard a little click in my voice a little bit earlier. I think that we who have children with special needs not only are going to be soft-hearted in certain situations, obviously it depends on the individual, but we can also raise our voice on occasion if that's what it takes. That's not our preferred way of dealing as an advocate, but we can go in that direction when that's necessary. We want what's best for our children, and we're the experts when it comes to our child. And let's talk about that from a family caregiving perspective as a whole. That family caregiver that you're engaging is essentially the person that knows that patient best. No matter how smart we are, what experiences we've had in that particular area of expertise, the family caregiver knows what pushes that person's buttons. They know what they like on a stove. They know what they like on the television set. And they essentially are the ones who can best impact what's going on with that patient and the patient's outcome. So not only should the family caregiver be part of the healthcare team, they need to be the center of that healthcare team. The implications for this. Certainly we need to find scalable interventions that can enhance cultural awareness from nurses, scalable interventions and evidence-based practice for caregiver competencies as a whole. But we also need to be looking at caregiver competencies from a standpoint of the professional. We can no longer just assume that we are kind, caring, knowledgeable people and that we're going to engage the family caregiver well. We have to be intentional about that. Just as when it comes to patient safety, we can no longer just take for granted that we're good at it. With 440,000 people a year dying from human error in hospitals, we can no longer just haphazardly think that we're good from a standpoint of patient safety. I would argue that that same thing is true related to aspects of the family caregiver engagement. So begin to look for research, begin to make sure that you're looking at the evidence around how you can help to reduce medication errors, improve caregiver response, reduce readmissions, and reduce costs. I mentioned the RAISE Act, but also the CARE Act is state law that mandates that the care providers identify the family caregiver, provide them with instructions, and engage them. And again, the AARP deserves all the credit around the CARE Act, which is passed now in 40 states. And I mentioned earlier the Assist Caregivers Today, the Congressional Caucus. Pay a lot of attention because there'll be more and more folks hearing about family caregivers in the future. So what are some of the recommendations? Certainly to formally identify cultural and ethnic backgrounds is important. Have a distinct part of each care plan specifically aimed at the family caregiver. If our care plans had not only those things that are happening with the patient, but also the goals and objectives and the things that we should be trying to accomplish and measure for the family caregiver, it really would change our outcomes. So give that some thought. You want to ask the family caregiver to document their priorities for learning and supporting the patient. Their priorities might be very different from ours. They may be in a place where they are looking for some things that are not quite as complex and perhaps not as related to aspects of disease process as our priorities are. And that's a critical thing for you to be including in your engagement of patients and family caregivers. For each visit, following up on the family caregiver issues, if you're doing some phone engagement of patients and their families, make sure you're doing that as well. And the last thing is to be sure you're including the family caregiver in the post-care evaluations. Promote greater adoption of person and family-centered care in all settings. We talk about patient-centered care so often that it's almost become white noise. It's almost like we need to give this a different name because we've got to be finding ways to get them engaged and involved. And right here, we've got the center of the team. In the first bullet, I think it's critical for you to recognize that the RAISE Act is intended to try to get the family caregiver not just on the team, but at the center of the healthcare team. We absolutely have to be listening to what they've got to say if we're going to be successful at getting them involved. Congressional legislation. There's new legislation in the Senate. Senator Kirsten Gillibrand, a Democrat from New York, that would actually provide paid family and medical leave. So this is something for you to pay attention to because this can certainly give us, the family caregivers, a very different approach. These two people are dear friends of mine. They started a home health agency in a little town in Louisiana in Cajun country called Ville Platte. And Deanie is a registered nurse. They took this over from Council on Aging, I believe it was, or the local parish unit, health unit, and built a nonprofit organization. And Deanie ran this for many, many years. Her husband, Ted, is a brilliant guy, and the two of them together grew their organization. Today, Deanie is in the throes of dementia, and her husband, Ted, is having some cognitive decline as well. And they're living in a care facility that suits their needs. Their daughter, Lisi Coleman, is the past president of our organization, and Lisi gave me permission to use this. Lisi, thank you. But the point I want to make is that even within our home health family, we've got lots of folks that are dealing with some of these challenges. So be aware of that. I've got references here, and I've been told that you're going to have access to the slides. So I would encourage you to dig through those references as you look for evidence that you can apply in your own settings. There can be joy in the family caregiving experience. This is my daughter, Brooke. In March of 2018, she was the feature model among 40 models. They had an activity called Couture for a Cause, and they raised money for the Down Syndrome Association. And Brooke was connected with a dress designer who's done dresses for people on the red carpet in New York and Los Angeles, Dallas. And she was the feature model of the night. 4 models were special needs models. The other 36 were all young women who were 6'2" and weighed about 90 pounds. Long story short, Brooke stole the show, at least from my unbiased opinion. Anyway, there's joy in family caregiving. And this is Brooke's family caregiving team. We have 5 children and a dozen grandchildren. This was our gathering last Easter, and we'll be getting together again this weekend. So a dozen grandkids, all nieces and nephews to Brooke, and grandchildren from our wife, Ramona, who's all the way to the left, and that's me in the white hat. So family caregiving is certainly going to be getting a lot more attention in the future. We're very excited to have the opportunity to talk with you about this and to give you a chance to hear a little bit more about family caregiving and think about it not only for yourself, but for people, for whom you're providing care. So thanks very much. And I think now that we've got some time for questions and answers, Shannon, I believe you're going to handle that piece.
That is correct. Please, if you have questions, use the chat or Q&A box in your WebEx player to submit those. If you're not seeing those at the moment, you can click on the icons on the bottom of your screen. One of them looks like a little blue bubble with an icon on it. That will open your chat window. Or if you click on the dot with the black circle with 3 dots on it, that will open up your Q&A box, so you can submit your questions now. And I'm seeing a few come in. Let's see. This first person here says, excellent presentation, so personal yet very informative. You mentioned the proposed legislation about family caregiver insurance. Do you have ideas or any other details about how a system like that might work?
From what I've heard, and thank you for those nice compliments. I thought my mom would be on today. I really appreciate that. Thank you. You can tell I try to use a little humor here and there, but I'm guessing I need to keep my day job probably. So that particular legislation is aimed at working similar to some other policy that's already been written in this area. And I don't know the other policies specifically, but certainly they're going to be plugging a lot of things from the Family Medical Leave Act and some other pieces. We are very early in the 116th Congress. For those of you familiar with health policy, we get a new Congress in after the election in November, and in January they're engaged for 2 years. So the 115th Congress just went out. We're in the 116th now. So the actual details around that are still in the process of being developed. But I am happy to dig into that a bit more if you would send an email with your email address to Shannon and the folks with HHQI, and I'll get you information on that. Thank you.
All right, and as a reminder, that email address, if you have any questions, maybe you're watching this as a recording as well and would like us to share that with Dr. Hebert, you can email us anytime at hhqi@qualityinsights.org, and we will pass those along regardless of whether you're watching this live on April 18th, 2019, or maybe watching it at a later time on the HHQI website or in HHQI University as well. All right, we have another question here that has come in. This one asks, what advice do you have for someone brand new to family caregiving?
Great question, because oftentimes someone finds themselves in that situation overnight. Some of our parents, or for that matter spouses, end up aging gradually or having a chronic condition, and they're pretty independent, and then all of a sudden we find ourselves as family caregivers. The important thing to know is that there are resources on the web, resources in a lot of cases related to a particular disease process. So, for example, the Alzheimer's Association has extraordinary work on their web, but also support groups. There are support groups that are available for you not only in person but online. Those can be very helpful. For those that are dealing with family members around the end of life, the hospice movement has been very good at engaging family caregivers and helping them not only through the nuts and bolts of the care process, but also from an emotional perspective and a spiritual perspective as well. Most of you who have hospices know that chaplains are a very critical part of what they do. But thank you. I think that that's an important question. The good news is you're not alone. And the other thing that I say on my radio program every week is that, as caregivers, we generally tend to put ourselves at the end of the line, but we've got to do a better job of taking care of ourselves as well. So thank you for that question.
All right, up next, this is a comment we have from one of our participants. This individual says, we are in the throes of addressing rehospitalizations, and you have given me several thoughts that I will use in addressing caregiver engagement. Also, I just had a new grandbaby with Down syndrome, and for me, this was a very timely presentation. Thank you so much.
So, as you can see, yeah, if you got a family member with Down syndrome, then you and I are family. So you can see my contact information there. I'm happy to talk with you and learn a little bit about what your experience has been. One of the great things about having a daughter with Down syndrome is I don't have to worry about wearing a name badge. And if I'm in an airport or at a conference or something and somebody has a child or an adult with them with Down syndrome, they're going to get to meet me because I'm an off-the-charts extrovert, and I find a way to come up and introduce myself. And on almost every occasion, you know, it takes 5 minutes for us to warm up and tell that we are family. So thank you. That's a great comment, and wish you and your family a lot of love from Cajun country.
Excellent. Next question asks, are there defined regulations of training for the family caregiver across all states?
There are not. Essentially, the family caregiver comes to that particular role out of necessity, and most of you know that while we can't train or someone who is unlicensed to do things that are in the realm of nurse practice, we can train family caregivers to do that. My suspicion is that there is research and work out there related to the best ways to educate people, for example, around taking care of a central line, taking care of a trach at home. Family members do that all the time, taking care of a ventilator. But the bigger picture from the perspective of broad family caregiver regulations around their education is not something I'm familiar with. If any of you are, it'd be great to hear from you on that, because that sounds to me like something that the Advisory Council for the RAISE Family Caregiver Act should be doing. And I'm going to go back to this particular slide, because I'd really love for those of you that are on the phone to have a little conversation together in your own organizations. What are some of the ideas in the direction that you would like to pass on to the Family Caregiver Advisory Council? Health and Human Services is taking this responsibility around the RAISE family caregiving policy very seriously. But as we know, a lot of our friends who are working in the bureaucracy, while they're really smart people and do a great job of digging into the research, they don't always have the practical experiences that we have out in the field. So just want to encourage you to pull some ideas together. And again, I'm going to suggest that you send those things to our friends at Quality Insights in the HHQI group. You're certainly welcome to send those to me as well, but you've got a built-in relationship with an extraordinary group of folks there at HHQI. Either place is great, because we're going to compare notes and conspire to make sure that the RAISE Advisory Council hears from us. Thank you.
Excellent. And you mentioned the phone, which is coincidental, because we were wanting to offer folks an opportunity who aren't listening through their computer speakers, but rather have dialed in on the telephone lines to jump in if they have any questions or comments. So heads up, if you're listening on the phone and you don't have a question or comment, if you could please mute your line on your end so we don't hear any background noise or anything like that. And if you do have a question, hopefully everyone doesn't go all at one time. But we thought this might be a great opportunity for folks who might have a verbal question or comment to chime in, as we've been getting so many great comments and questions through chat and Q&A. So, Misty, are our phone lines unmuted at this time?
The phone lines
okay, everyone's unmuted. If you have a question or comment for Dr. Hebert, please speak up now. Okay, I think everyone's a bit bashful to be on a national webinar, maybe by voice, but we are continuing to get good questions and comments coming in through the chat and Q&A message. I just got a message actually from here in West Virginia, where I'm located, and very complimentary. Said, I absolutely love this presenter on the UP webinar. So some great feedback from right here where I'm from as well, in West Virginia.
Shannon, I hope it's okay for me to say I love you too. Thank you.
Excellent. All right. Let's see. I'm seeing, I believe, one more question queued up here. So if you have any additional questions or comments, please make sure to get them in chat and Q&A before we wrap up today's webinar. We do have more information coming up about continuing education and some HHQI resources in HHQI University, and we'll also revisit something we talked about a little earlier, which was the Raise Family Caregiver Advisory Council. But at this point, the last question I'm seeing in Q&A says, I really love the team approach to caregiving that you have demonstrated through your own personal experiences. Do you have any tips for recruiting members of the team who may think they're too busy or maybe too far away geographically to be able to help with family caregiving?
Oh, I love this question. Thank you so much. One of the most important members of the care team is the long-distance caregiver. You can pick up the phone and call a loved one or somebody you care about. And I've been talking about family caregiving. Another moniker is the informal caregiver, because not everybody is related biologically as family who's part of the care team. So people may think they're too busy, but the truth of the matter is picking up the phone and calling can be something. Going by just for a visit is something that can help. So that would be another thing that I would encourage you to do. If you know someone who is a caregiver, just to go drop by and visit. Usually the person who is dealing with the illness, the functional challenges or cognitive challenges, is the one that gets the attention from everybody. The family caregiver, as I said earlier, is primarily ignored. So that's one of the things that you can do, is just to tell them to come by and visit you if you happen to be the caregiver. The other thing that I would encourage you to do is to find surrogate family. Within our church communities, one of the most critical aspects of family caregiving is trust. And there's built-in trust usually within our faith communities, within the different wisdom traditions that we participate in. And if you can find people who you've had relationships with there, the big challenge is getting them to be vulnerable for that first visit, to take a risk on that first visit. And they'll find out that their fear of the unknown is something that is far greater than the opportunity to be able to engage somebody. But that's a really important question, because we've got to be finding ways to build our care team and build relationships. Thank you for that question.
Sure. And well, we've had actually two more squeeze in. I think we've still got time for those before we get to the top of the hour. This one says, do you have any advice for those who have been a caregiver for years and suddenly finding themselves out of that role after a loved one's passing?
Mm-hmm. Wow. Yeah, that's something that a lot has been written about. And it's a pretty significant experience. You know, most people would hear that and say, oh, gee, you know, the person's going to be really thankful now they don't have all of that engagement and all of the challenges that go along with that. But when we identify ourselves as a family caregiver, and even though if you don't do that overtly, your self-worth, the meaning that you find in caregiving, is something that is certainly become part of who you are as a human being. And when that person dies and there is this sort of disconnection, it certainly is a challenging time. I would encourage you to find a person who is a thoughtful friend who can listen to you. If you happen to be able to access a counselor, sometimes clergy can help. But the other thing that I think is part of your aim for a longer term when you feel you've healed, and that is to get back and helping other caregivers. Your experience is so rich, and others who have not been caregivers before need to hear from you. They need to know what your experience has been. So certainly thank you for that time you spent as caregiver, and all the best to you as you transition through that experience.
All right, and we have time for one final question, and this is very timely because we had previewed before that we would be mentioning again the Family Caregiver Advisory Council, which I believe we had in a previous slide here with information on that. And while we look for that slide, I will share the question: who will be on the Family Caregiver Policy Council, and how do we provide input on this council?
Well, I am really hoping that you already know somebody who's going to be on that council. I had nominations going back in December, but the people that are going to be on the council, as I said a little bit earlier, and Shannon, you were trying to find the slide. I realized earlier I went to this one, but it was farther back up. The people that are going to be involved is there will be some people from different government departments that are going to be involved on the advisory council. There are also going to be folks who are family caregivers, people who are beneficiaries of care. I'm certain that our friends with the AARP, because they've done such important work in this area, hopefully they'll have some people involved. People with disabilities. Veterans receive a lot of family caregiver. So along with these folks, there will be some people who are part of the administration of community living and other people in health and human services. But thank you for asking that question. Hopefully you know somebody who's on there. I'm really looking forward to it. The question, though, was how we engage. Continue to connect with the folks there at HHQI, at Quality Insights, and I'll stay connected with them. But you've got my information. If there's something that you want to communicate to me around suggestions, I am going to be involved with these folks, whether they accept me on the advisory council or not. They're going to be hearing from me. So I'd be happy to sort of serve as a conduit to make sure that we're getting good information of those folks. Thank you.
Excellent. And you see we have Dr. Hebert's contact information directly there on the screen, or as he mentioned, you can reach out to us anytime at hhqi@qualityinsights.org, and we'll be happy to pass the information along. Before we conclude, I just want to sincerely thank you, Dr. Hebert. This was a phenomenal presentation today, and I know so much positive input and questions that we've received, and we sincerely thank you for your time.
Shannon, I'd like to leave you with an African proverb, and it says, if you want to go fast, go alone. If you want to go far, go with others. So from a family caregiving perspective, find a team. Thank you.
Thank you. And just a few resources you see on your screen in HHQI University. These can assist you with working with patients who have caregivers. These would all be useful to you as well. And this slide provides a sampling of a variety of educational materials available for patients and caregivers to assist with managing their care at home. You can go into the complete online HHQI resource library to search for disease-specific materials, or feel free to reach out to our inbox for individual assistance. To obtain continuing education credits, please follow the directions from the slide or the email that you will receive immediately after this webinar to complete the evaluation. If you can't recall your username for HHQI University, please reach out to us at hhqi@qualityinsights.org. On behalf of everyone on the HHQI team and everyone at Quality Insights, we'd like to thank you for joining today's Underserved Populations or UP Network webinar. We appreciate your feedback at any time and hope you have a great day. Goodbye.